times, especially if you include after-school care. And type 1 diabetes doesn't go away just because they go to school, right? School staff require diabetes management and education to support the students with type 1, so they're able to remain successful in their academic and childcare settings. Children with type 1 diabetes, and you can probably think of many more bullets for this, they require accommodations in the school setting. 504 plans, IEP plans, DMAF, that's a diabetes school orders, supplies in nurse's office, classroom, and wherever they are in the school setting. Technology, and this includes their cell phones, yearly training for glucagon and other diabetes therapies, substitutes, hallway monitors, staff, security, just being aware of diabetes, special teachers and after-school staff, sports care, child care during field trips too, emergency drills, go bags, that includes bags in the classroom for lockdown situations and what to do during those situations, emotional support, phone and tech support. You know, a late trend this year is kids have to put their phones in pouches when they go to school, and our kids simply can't do that. Their phones are their lifeline during the day. Next, please. So our identified problem. Yep. Yay. I got it. Thank you. Our identified problem. There were no official streamlined education plan for students in the school setting, especially transitioning with type 1 diabetes back into the school setting. You know, we learn from our families, and we have families typically back in the day before our program, you were diagnosed with diabetes, you left the hospital and or the office, you came back for the new onset class, we give you your orders, we tell you go to your school nurse, give these to your school nurse, and please be available to support your school nurse. Our cell phone number and our phone numbers are all on the school orders, and they'll reach out to us if they need anything. Wow, that's a lot for our families, right? This is a very stressful time. So we recognize that schools were unable to provide support and education necessary to staff at diagnosis. There's no identified contact person. Schools and support staff, they're resistant, and they had concerns, and their concerns were just out of care for the students and their lack of education. So everyone involved lacked the time and the resources. And provider, staff, youth, family concerns at diagnosis, childcare settings included, are not all set up to care for our kids after diagnosis of type 1 diabetes. So the purpose of our quality improvement was to increase our education and support sessions by 20% each year for the first 3 years through the development of our program. Additional aims are improving the quality of care and education, offering programs and initiatives, and continued work and support with the DOE and DOH through collaboration. CDC 2020 is when this program started, and that was when my role was designated to begin support and education for the schools through our program. We reached out to schools, so our goal is to be there at diagnosis. We meet our families at diagnosis, and we go into schools and support the schools at diagnosis as well. Created option for additional diabetes classes at diagnosis, our Safe at School event, and school staff education day. We continue to meet with NYC diabetes centers. We collaborate with other diabetes centers in New York City to discuss DMAF's 504 plans and ongoing care and support for children in the school setting. 2020 to 2021, the first full school year our program was active. We created a dedicated email and cell phone for all parents and school staff to discuss school's concerns, and also for school nurses to text and communicate throughout the school day. Created an online option for requesting school forms. We do this through RedCap, send a link to our families, and we can get school forms back in a timely fashion. Quarterly Zooms. They grew in 2022 to 2023 to monthly Zooms with school staff, educators, and parent support. School bags, this was huge. We noticed at diagnosis and then in through the school, our kids were going to school with those little bags that you get when you're discharged from the hospital with stuff in it. So, can we get bags for our kids so that they have a place for their diabetes supplies in the school setting? So we give them school bags at diagnosis. I've extended that to school nurses and paraprofessionals because I noticed they were carrying around the kids' supplies in little zippy bags. So now that our kids have go bags. Protected time for my job, yay. Surveys and questionnaires that we give out to families and staff RNs, and planning the 2024 school conference. Our results, 26 sessions in person and online in 2020, 2021, that grew to 35 the following year, and last year, 60 sessions. So our education sessions did increase by more than 20%. I like some of the survey questions we get. Diabetes is huge, right? 51 respondents to one of the questions we asked the school staff, and 17 strongly agreed that they felt comfortable with technology. 27 reported limited education and understanding, and 7 disagreed or strongly disagreed. Technology is a very big thing for school staff to learn, and it's ever evolving. And those have my most turnouts for my monthly sessions. Quotes from school staff, I'll just read the last one. We need consistent support from the healthcare provider and parents and school administration. That closed circle really takes a lot of stress from our families, and the schools really feel supported knowing they have a direct contact to the provider's office. So future steps, more quality interviews and surveys, knowledge assessments, increased events. We're planning our February 3rd, 2024 school staff education event. Find me about it. And we continue to ensure students' needs are being met. Legal action and advocacy. Can't talk enough about that. Continue to meet with NYC, DOE, DOH, and other centers to collaborate care and support for our kids in the school setting. So one of our biggest steps was creating this program, seeing the need and moving forward. Nurses and school staff are utilizing our services at the center, and additionally, school nurses report a need for more. They want more education and support. This will only increase due to the release of new technology, which is good for our kids. Thank you. Lastly, I would like to thank my supporter, the Dubin Family Fund. My job would not be possible without the generosity of others. So, questions? Yes.
So I think recently, in April of 2023, New York City was in a special situation for the school nurses because there was a lawsuit that was against New York City public schools. So there is a new kind of resource from the Department of Ed and Department of Health. Are you able to use that kind of mechanism to support your program?
And they also have online trainings that are now given to schools before the kids go back. Hopefully that's their initiative. And then I communicate with them daily as well. Mm-hmm. Yes.
I think
Thank you.
Thank you very much. Really, really great presentation. Okay, so who is next? So how do we move this forward? Do I do this or you guys do it? Just press this forward, okay. Great. So next speaker, we'll be talking on patient involvement to improve new onset type 1 diabetes education, which is also once again important on the adult side too.
There we go.
Thanks so much.
Okay, so I just press this button, I'm assuming?
Yes.
Okay, great.
Hopefully go forward.
Okay, hopefully.
Hello, my name is Isabel, and I am a dietitian and diabetes educator at Cornell. And I'm going to go over our initiative to improve diabetes education for new onset patients with new onset type 1 diabetes. Okay, so how this started, I'd say around the start of the new year, some staff members were bringing up concerns about patient gaps in knowledge in terms of what they're learning. Inpatient, outpatient. I myself am only outpatient, so I was like, I don't know what's going on inpatient. Not that it's anything bad, but like, what are they learning? What are they coming to me knowing? So that sort of started this project, and how can we make this a nice smooth transition and make sure that we feel that patients are well educated during that process, that really overwhelming process of a new diagnosis. There's not a lot of research on this topic, and the thing we do know is that engaging patients in decision-making can improve quality of care. So here is my KDD. Oh, it's going to do everything separately. Oh, okay, great. So our aim or objective here was to standardize the diabetes education for patients newly diagnosed with type 1 diabetes by utilizing patient and family feedback. And so what we're really going to focus on is the patient education, provider education, and the peer support components. Here are our PDSA cycles. I'm going to go through these more, so this is more just the timeline of it. So what we started off is we gave a survey to our staff, and that included attendings, fellows, nurse practitioners, RNs, CDCES, and administrative staff. And we wanted to know, what concepts are you getting calls about right after diagnosis that patients are having concerns about? What are some things inpatient that you feel patients aren't fully understanding? What are you thinking outpatient? So I gave that first to staff, and then we did a pretty similar survey, which we sent out to patients diagnosed within the last 12 months, basically asking them the same questions like, what are some concepts that you find that have been challenging to understand once you're diagnosed and such? And then this is a bit of the results. So this is the inpatient results. So as you can see, the providers were thinking that the biggest questions and difficult concepts were around insulin dosings and corrections, followed by carb counting and hyperglycemia. Whereas patients overwhelmingly said that carb counting was one of the most challenging concepts to understand. So this chart was just helpful for us to learn, oh, okay, yes, these are things we want to go over, but maybe we need more resources in this department than we thought we did. And then outpatient. So they don't line up perfectly, and that's because we gave out the provider survey first. But anyway, we can see the education gaps, which does include the carb counting, insulin dosing, hypo and hyperglycemia, were overwhelmingly the concerns that patients had the most of. And again, carb counting, inpatient and outpatient. So that was where we were like, oh, we got to focus some more on that, as well as the insulin dosing. Okay, so the first box here is some quotes that patients wrote in the survey, because we had open-ended. It was a Qualtrics survey. We had some text boxes. I think some of the main takeaways is a lot of the focus on what was challenging was returning back to school and returning back to everyday life. So not even necessarily just concepts like insulin dosing and carb counting, but more of that, how do I take what I've learned and how do I become a person with diabetes in my old life into my new life? Outpatient, carb counting again. So these were just, again, some of the quotes that came from the survey. And then something that we simultaneously started during this QI project is we started a family focus group, which is a different version of an advisory council. And it's something that we are doing to try to get patient perspective as well as parent perspective. So we started our first meeting. Our goal is quarterly. It's going to be eventually patient-led. Right now, since we just started, it's a little bit more provider-led. But we asked that group, like, okay, when you were diagnosed if you were diagnosed at Cornell, what were things that during your time you were like, oh, I wish I learned more about, or how was your experience? And so again, a big takeaway was, I'm going to just skip down. It was more community support. So that's really another highlight. It's like we took away from this, carb counting, community support. And that wasn't what was necessarily on our brain when we first started this project. Okay. So something else that we did is, as I mentioned in the beginning, we don't have like a an exact standardized, like read this script when someone's diagnosed with diabetes. And every provider has their own way of teaching, but we did realize there were some key concepts that providers were giving based on their training and based on recommendations that are not necessarily concrete, gave different guidance about. So the topics that were sick day management, overnight blood sugar management, and ketone management. So as a diabetes team, we met together and we agreed on how we wanted to educate patients about these, if they call with ketones, if they call in the very beginning of diagnosis, how often do we want them to check overnight for blood sugars? What do we want them to do if they have high blood sugars? So we made it, we had made a consensus about that. And then we sent out, or we're in the process of educating our whole division on, those kinds of guidelines going forward. Something else that we thought would be really helpful is why don't we see, after patients are taught all this, the hospital, like what have they learned? What have they retained? So we created diabetes knowledge assessment. So this is a quiz, I would say like 10 to 15 questions. I can't remember exactly how much. We tried to cover all topics, carb counting, insulin dosing, even confidence going back to school. And so our goal is to give this quiz out at the first outpatient visit. We figure that inpatient, there's so much material, and to go over the concepts like with them and say, okay, let's go over the questions you have. Because someone mentioned earlier, if you say like, do you have any questions? They might say no. But if you really go through this, it's easier to find out, okay, what are some things that we want to dive more into? Along with that, we want to translate it to Spanish. We want to have our social worker help look at it for health literacy and make sure that it is clear from that standpoint. Okay. And then things that we want to continue to work on with this project and this initiative is utilizing our diabetes educator. So myself more for outpatient education, for just diabetes education, not just in the RD role, providing more resources. So we did develop a carb counting booklet that we want to give inpatient for extra support, that we're going to have patients go over. We have a lot of hopes and dreams on this one. We want to do diabetes discharge videos. So our goal is to make like 3 videos, possibly a carb counting and insulin dosing one, and then just like play out scenarios, sort of like if anyone's ever been at a hospital and they have to watch like the shaken baby video before they get discharged if they had a baby. So that was the thought on that one, but we need grant funding for that. And then continuing the patient and parent involvement. So the family focus group, we have a dream of doing like a monthly class for new diagnosis for patients to get to know each other. We are working in a lot of not completely related, but like a teen group, and we have a camp, and we are trying to build up our community support. And yeah, so that is really what we're working on. Okay, great. So thank you.
I think we have time for maybe 1 or 2 questions at most. Any questions? Wow.
Was it a paper survey?
So we first emailed it out for patients, and then actually I would like look at the schedule and be like, this new patient is coming, and ask one of the doctors if they could give it to them even during their clinic visits. So we really did target. We're a smaller center, so we didn't have like that many patients diagnosed within the last 12 months that we were able to like make a list and go through that way.
Another one.
I'm gathering from your speech that your program, all new onsets are first admitted to the hospital. And so you don't do any outpatient education for new diagnosis? Okay.
I had 2 questions. One, do you, is it in your practice that you do an assessment of what's the digital literacy level, what's the health literacy level, or kind of getting a baseline and then adapting the program accordingly, and then also adapting the program culturally, whichever culture they may be from?
So 300,000 Angelinos trying to find their way to work made me late for the airport. So I missed my flight. So I'm definitely thankful that I'm here today. So again, this is just speaking about our journey in our QI project that led to try to improve smart pen uptake. So in 2022, we were invited by the T1D Exchange to participate in a QI project that was trying to increase equitable access to connected pens data use and shared decision making. These are aims that we're trying to increase connected pen dosing data availability by 10% from baseline to 9 months. We're looking to increase shared decision-making documentation using a diabetes technology assessment tool for eligible patients on connected pens by 25% from baseline in 9 months. And that we're looking to increase A1C levels, reduce racial inequities, and increasing time spent educating patients on connected smart pen use. So this was our workflow that we created in terms of how we were navigating our patients, our families onto smart pen, leading to different vendors and having authorizations, a smart pen setup, and smart pen utilization. So this is our initial PDCA cycles where we use the diabetes technology assessment tools. In cycle 1, we had about 5 families that were using MDIs. And in cycle 2, we led to 5 MDIs and 5 CGM families. And poor Ori's here in the room, and poor Ori kept hearing say, you know what, Ori, I'm not sure if this DTA cycle is really working for our population. And so she gave us freedom to kind of navigate our own way and come up with our own strategies to try to implement this tool and the shared decision-making process. In cycle 3, we asked the independent provider and said, hey, you know, can you use this tool? Is it helping you facilitate these conversations? And she also felt like it wasn't really doing it for her. We led to then cycle 4, in which we had a technology laminate. So this was provided us by Type 1 Diabetes Exchange. And I think this is from my colleagues at Stanford that provided this, which was a great tool in terms of giving some visuals for our families of what these technology sample boxes, this technologies look like. One of the things that I experienced with my families, though, is that I would show them the laminate and they would squint at it. They wouldn't be able to see it. There's also some concerns about, is there a literacy issue? Is there a language issue? And so I started thinking about one of my families that asked, well, can I see it? And that led to cycle 5, in which we started developing these diabetes technology boxes, where we had different vendors, samples that are in there that we could utilize to help facilitate discussions. In parallel, CHLA worked with one of the vendors to try to develop a different workflow to increase our smart pen use. So this was a smart pen that had a chip that was designed to only last for 1 month. So after 1 month, they would no longer integrate with their app, and they would have to use their sort of prescribed smart pen in the future uses. One of my families asked how that works. Will it actually blow up on them? And I said, I don't think so, but I didn't make it, so I can only say I don't think so. So between December 2022 and April 2023, we documented 45 shared decision-making instances. 34 were for type 1 diabetes, 11 for type 2 diabetes. 18 of those families were already using CGMs. And we could see that we had a pronounced uptake in terms of those that opted for technology based on utilizing this sample boxes. So 29 opted for technology changes, that equates to about 64%. 19 went on to CGM, so 65%, 8 to insulin pump, and 6 to smart insulin pen, 20%. So I said that I was going to share my journey. Unfortunately, all of our smart pen candidates ended up not going on to smart pen. And so some of the barriers that we thought we saw was that we were giving out a sample smart pen in clinic, but it was around the time that our vendor stopped giving us the cartridge samples. So we no longer had cartridges to actually start at the day of the visit, which I think was very important for momentum. We were losing momentum when we started prescribing the smart pens. So that was definitely one barrier. The second was still going to be the copay related to getting the next smart pen, because I had families that ended up using the samples, but then never heard back from the vendors to get their replacement smart pens. And there's also the language barriers. We always had trainers that had to try to call families to go over the training. We didn't have the clinic support to be able to do it on the day of. Again, just kind of lack of momentum moving forward. But again, with every failure and the journey is that I found the silver lining in terms of the QI project. That we embarked on this journey to try to increase smart pen use, but found a different modality and a different clinic change that we were able to institute in our clinic. And basically we have technology sample boxes that are laid out in all of our rooms that our providers can use to basically show families. A lot of responses are, wow, that's actually smaller than I thought it'd be. So they will see and feel and touch the different technologies that are out there to help kind of discuss what are the best options for our families. And, oh, sorry. That's all I have.
Thank you. So, yeah, time for, I think, 2 quick questions here. So go ahead. And then I'll hear that.
Well, mine might start a group question. We, in general, have had similar experiences with smart pens that just the uptake isn't there. They don't stay on it. They end up back for some reason. They can't get a cartridge, so they end up back on the pens. I know some of my counterparts, like I know up at Monty, the PEDS program had good success. So I'd be interested in anyone who's had good success. No, okay. So you're not alone.
Great. I'll let you go first and then I'll let you share your success. All right.
Thank you. Very nice. I was more intrigued with the 30-day chip technology. I had not heard of that before. Is that something that Medtronic provided you with? And
I think there are a few clinics that might have participated based on what they're telling me. So it was based on, technically they would have liked us and our institution to do the training. And I think that's where some of the breakdown happened, and that we didn't have the manpower to do it. So we had to ask them to do the training, and then that just kind of fell through the cracks.
So Jeniece, how'd you get the pen started so successfully?
So, I mean, most of our patients, if they're not on a pump, they're on an InPen. And we pretty much just recommend it for everybody who's not using a pump. We do have to work a lot with our prior auths to get that. We do have the 30-day InPen now that we are able to give out to patients. So it's a good start with them to get them convinced to use it. And the prior auths are a problem. The other thing is Medtronic will give you a $35 InPen. If they're refused, the insurance is refused. So the majority of our patients can afford $35. Pens are super expensive if you lose it, so never lose it. And sometimes you can get them to use the app, even if they're not using the InPen, and that's half the benefits is the app.
Great, thanks. Okay. Moving along. Very nice presentation. So far, these have all been great. Okay. So next one I'm going to make very short. I'm going to say this is the IDEAS program, Integrated Diabetes Education and Support.
Thank you. I'm Tammy Hanon. I work at Indiana University, Riley Hospital for Children, and I am presenting on behalf of my colleague, Anna Naiman, who really drove this program when she was at Indiana. She's now in Cleveland. At our diabetes center in 2022, the percent of patients with type 1 diabetes who were admitted to the hospital with DKA or another acute complication of diabetes are listed here. 7% of the total population of youth with type 1 diabetes in public insurance, and 2% of youth with type 1 diabetes in private insurance. We care for children across the state of Indiana. We are the main children's hospital in the whole state of Indiana. And we have 6 satellite clinic locations throughout the state of Indiana. So we were interested in decreasing the rates of repeat episodes of DKA. As we all know, DKA is potentially fatal. I don't need to go over that with this group. So we started the IDEAS program, Integrated Diabetes Education and Support, to really organize the resources and support that we had to care for patients who were presenting with a repeat episode of DKA. We knew what support they needed in a broad sense of the word, but when they were admitted, the emphasis was on trying to get them home as soon as possible. And we weren't always able to provide the education and support that they needed while they were in the hospital. So, we developed a pilot program for patients with type 1 diabetes who were admitted to the hospital or the emergency department for diabetes-related reasons who were at high risk for readmission in the next 2 years. As determined by previous admissions, their diabetes care provider, educator, and they should be referred to the IDEAS program, which included a group of a social worker, a pool of diabetes educators, and a health educator / health coach. Our key drivers were really to reduce hospitalizations for DKA with a secondary aim of improving hemoglobin A1C in participants of the program. And a tertiary aim was to facilitate the use of CGM in patients who had a repeat episode of DKA. Our primary drivers you can see listed right here, and I'm going to skip fast over that last slide and show you some results. So in 2022, I'm just going to say left column, right column. In 2022, we had 58 patients who presented with DKA, and we had 14 of those referred to the IDEAS program. I should tell you a little bit more about the IDEAS program. So the IDEAS program ideally would have a social worker follow up with the patient either while they're in the hospital or the week after their admission. They would also have a diabetes educator meet with them in the hospital, but more ideally the week following admission, and then their primary diabetes provider meet with them within the first 2 weeks. So you see here that 64% were males. The race ethnicity breakdown is on the right. The public insurance is noted there, and technology use was particularly low in the IDEAS referral patients. Most patients in this group had more than one admission for DKA overall. All of the patients who were referred, all 14 consulted with a social worker within the first 1 week of diagnosis. One of these participated in integrative health coaching for a period of 16 sessions and had a reduction in hemoglobin A1C of nearly 2%. 7 had repeat A1Cs that we were able to measure after the baseline, and there was a trend towards reduction in hemoglobin A1C. You can see that in the graph. One individual had a particularly precipitous decrease in hemoglobin A1C, and 1 of 11 had a DKA episode after participation in the program. That particular participant had 5 previous DKA admissions in the year and only 1 DKA admission after this. So we're hoping that this stays to just 1, but this participant has not been admitted to the hospital now for the past 5 months, and hemoglobin A1C decreased from 14.4 to 12.3%. So really, I want to say the key points of the Integrated Diabetes Education and Support Program was not that we were offering really any new program. It was we were really standardizing the process of the contacts that the family would have and how many times we would try to contact the family, and then offering families, if they wanted, to meet with a health educator or coach every single week to work on a goal. So we were providing what we felt should be standard of care, but the resources aren't always available, and definitely the process to do so isn't always available. So I wanted to thank all the amazing team where I work at Riley and the people who helped us do this program. We're continuing this program forward, and I want to say the next steps, which I don't think I showed a slide. No, I didn't show a slide. But the next step was the tertiary aim was to work on that 50% use of CGM in our patients. And we developed a technology station in our clinic to do that. So 100% of patients after a diagnosis of diabetes, we're putting a CGM on them. It's usually a sample CGM, but then we're doing the prior authorization so that when they come back, we have all the supplies through grant funding. Fortunately, we have all the supplies to keep them on CGM, and we've had a very high rate of success with that program. Thanks for allowing me to speak.
At the beginning, you mentioned diabetes educator, provider, and health coach. Can you tell us a little bit more about what the health coach is?
So I direct our youth diabetes prevention program, and we hired 2 health and wellness coaches for that program about 10 years ago. And we decided that because we didn't have enough diabetes educators or social workers to follow patients in the IDEAS program, that we would have the health and wellness coaches do that. And working together with the social workers and the diabetes educators, it's been really, really nice. Fortunately, there's a lot of overlap in their expertise. But there's also just another person who has time and has, can meet with families and has very good expertise in motivational interviewing and also helping families follow through on their chosen goal. So that's why we did that.
It's actually a follow-up question on the health coach. So what is the scope of practice of the health coach? Are they hired by the hospital? Are they hired by administration? Do you contract with them? What is their education level? What is their salary? like getting into details, like what, I don't think I actually know what a health coach is.
And the same question is who's paying for it? Because that's always the challenge.
So I'm pretty particular about our health coaches, and they are both have master's degrees in health education, and one also has a master's degree in public health. They've both obtained their CDEs as well. Our program pays for them, our diabetes program. So the Diabetes Center of Indiana University Health pays for all the diabetes education. They do not pay for the health coaches. So the health coaches are being paid through grants, through pediatric endocrinology, through a totally different fund.
Educator or health coach follow-up, and then PCP follow-up. How did you connect that PCP? Because we don't typically see the PCP collaborating with the office. How did you get that PCP, and what was the buy-in of the PCP, and how does that information flow happen back?
That's a good question. That was a primary barrier for this program because the PCPs didn't have any follow-up. slots open. And so the PCPs were kind of like, why am I seeing this patient in 2 weeks? You know, I have an appointment to see them in 3 months. And so getting the buy-in of the whole team that, you know, this patient might need to be seen more often. Also, we didn't have the resources for, you know, let's say I just opened a new clinic and do, you know, see all these follow-ups. We didn't really have the resources for that. So we had to, our PDSA cycles, and my apologies that slide wasn't up here. Our PDSA cycles were around that issue primarily because we couldn't get the patients in 2 weeks. We had to say, okay, we're going to get the patients in within a month, and then we're going to have to ask people, specifically diabetes care providers, to, you know, sort of expand their, to be a little bit more flexible with their templates. And I didn't answer you about the how much a health coach costs. It costs about as much as a registered dietitian.
Thank you very much. Can I have the clicker? Yeah, thanks. I do that all the time. Okay, so moving along. I think this is our final presentation, so we're good on time. So T1DX Learning Collaborative Convention, Diabetes Patient and Family Focused Group Program, a new initiative to incorporate the voice of a consumer. Very important. Thank you.
Thank you. It's a pleasure to be here. Hi, everybody. So I have some of my notes here. I click here. This one. This one. Okay. All right. So at Nationwide Children's Hospital in Columbus, I'm a clinical social worker, so I loved hearing a lot of social work mentioned today. And I also co-chair Hospital Family Advisory Council, and I do some health literacy work, and I also program coordinator for Connecting Families Mentoring Program. So how does this focus group come about with our patient and families? And Dr. Campbell, who's our chief, she's right back there, raise your hand. She attended a few meetings and she came in QI and she mentioned to me to develop this program. She said, Toyetta, go develop this program. But anyways, I did, and it's very successful and we love it. So this is our objectives here. I'm not going to read everything to you, but I just want you to, the key points is communication was what I want you to take away from this. It's so important. Camaraderie for the families, patient and families, hearing their voice, hearing the feedback and the viewpoint. Okay. So the next slide. This is our aim. I thank Don, he's presenting right now in another room, for helping us with this. And this is our aim that we have here, pretty much focusing on sharing the perspective of families to improve the clinic experience by meeting with the clinical staff and families. So pretty much we met with them 2-3 times. I will put together this focus group based on the month. There's a lot of factors in place, sick of time. The recruitment efforts really depend on who we're inviting. Type 1 patients, sometimes and type 2 patients, little ones, 3-year-olds up to whatever age, young adults. It depends on the topic that we're having for the meeting. We're very intentional. I'm very intentional on the topics. They have to flow relating to what we're going to do for that specific focus group. We feed the patients a little light dinner. We send out information through MindChart, through mailing, and have paperwork in clinic. So that's just some of the ways that we recruit. The next slide is our PDSA. This one shows that we had 8 focus groups. We actually had 9 last Wednesday was my 9th one. And Dr. Indike, who's back there, has always been supportive in attending and helping to present. So without going through all of this, some of the topics, anything you can think about that you would do in endocrinology pertaining to what you want your families to learn, your patients to learn, is what we do in our focus group. So it could be from A1C to sick day management to bolusing, carb counting, etc. We also have we are multidisciplinary teams. So one of the things we do is we ensure everyone have an opportunity to present to our families. And then we have extra staff that will come just to help answer questions and be engaging with our families so they can see this team support. So once again, being intentional is so important for our families. And we have fun. I don't want it to be where you go to clinic for education, your new onset, you get education, just strictly sitting there getting education. Is more of having the kids there, having the parents there, the kids can play. We do, some of you might know the song, the Hokey Pokey. You put one in and yep, we do that. The kids love it. They'll get up there and dance. The parents love it. They'll get up there and dance too. So I want people to feel very relaxed. And so we tend to go to, sometimes I'll do it hybrid. Sometimes I've done it all in person. Other times I've done it virtually. So it depends on the month, once again, and the situation. Next slide, which is a little picture that was plugged in there. We select pre-plan the topics. The presenters are pre-selected. And that's Dr. Indyk in there, actually. All right. I just wanted to show another picture of some of our focus groups. So that's what that is. And some of the topics we cover also: insurance, resources, and so forth. This is another picture we have that we created this true or false signs and make it fun and ask the kids questions and their parents on what is true and what is false relating to diabetes. So they love that. Some of the kids, I got them to sit together by age. So it's nice for the kids to experience being together. I will say that this focus group in particular, we did allow teenagers who wear CGMs and pumps to see other kids who do not wear CGM and pumps. And those children in particular who did not were interested in wearing it by the time we're done. These are some of the results that occurred. And I'll just kind of go through, I took some notes to share with you. So some of the things that's so crucial, early on in the main room, I mentioned health literacy. And it's so important because health literacy, if you know about it, will decrease urgent care visits, it will decrease emergency visits. If you're a doc and you're on call, a nurse practitioner, it will decrease some of those phone calls late at night after hours. So because you want to give them the knowledge, but reinforce it in the focus group in a different way. So some of the families that come, they return for the education. We learn about JDRF, give them more resource and information. Some of the parents will share books with each other. Like I said, sick day, they said it's scary. That's where some of their feedback. They felt that you listened to the perspective. They felt valued when they attended this and we listened to their feedback. Kids said they're nice seeing kids their age, whether they're little or preteens. Families felt that it wasn't like a serious education. It was more of, this is what I want to know, and you're providing that because they know the topics before they show up. We have an education binder with all our disciplines, multidisciplinary team education that we give to a new onset. So they mentioned how that is so crucial for them that they can return back to that binder and be able to maneuver throughout the day. They feel that we're committed to them. But, you know, real quick, I just want to end with a little story that I've shared before, and I'll share it again. There was a mom that called me to register her little one who's diagnosed with type 1 diabetes. And she did on the phone. She was really overwhelmed and had a lot of anxiety. But she shared with me some challenges in her family. So she attended the focus group and registered. And just keep in mind, it's not only the parents and the patient, I invite siblings also. I also invite support, whoever they feel is their support, because we talk a lot about culture. So a lot of cultures, it might not be mom and dad, it might be grandma, it might be the aunt or the grandparent. So anyone can be invited. So with that being said, anyways, that family came and I have little toys at the end, little prizes we give them. And this particular mom came up to me after her two little girls came to get the gifts. And she said she felt so relieved when she attended this. And we didn't understand how this had helped her so much. So the issue was the daughter that was diagnosed when she attended clinic for follow-up, her sibling thought she would die and never return. So that was the challenge. You know, when your child is diagnosed with a diagnosis, that's overwhelming in itself. But when your sibling at home, another child, thinks you're going to die when you go to your follow-up appointment, that was even more traumatic. So because we made things so much fun and comfortable, even though we're still learning, her daughter, the sibling, felt so relieved and shared with mom, "I love to come back again." So I share this because, you know, a lot of times we have what we want to share with families, and we need to mix those perspectives, what we want and what they want, and how do we collaborate together with everyone. So I thank you for today.
Lovely, thank you.
Thank you. I love this. Great presentation. My question is, we're trying to do a lot of, you know, collaboratives and peer support and such with our patients. And I have a lot of trouble with recruitment and buy-in. And from that picture, it looks like you had great success. So I'm curious if you have any secrets. I know you said it was dinner time. Was it like after they had gone to clinic? Any feedback on? Yeah.
Yes. It's always in the evening. So I know it's a long day, but it's convenient for families, whether they work or not. So I begin registration about 4:45, and then the program starts at 5. So with that being said, we have pizza and salad. We have cookies, you know, whatever, and drinks. The dietitians will write out the carb for each, and then I'll post it on there so they can see their kids. Recruitment, like I said, we have different ways of recruiting. If you want to be intentional about ethnic group, you can be. So it's fine for you to be intentional about that, but you can't not invite other folks. So in clinic, I always ask the doctors and the whoever's in clinic to help us during clinic time so they can talk with their own patients and say, "Hey, this is a great program, why don't you attend?" Because when you're familiar with your person you're seeing, you tend to listen to them.
So on that note, like with people attending, sorry, a theme, whatever, we're in New York City. So like, yes, we'll try to meet up, but we find like getting patients to come to us at 5 o'clock or 5:30, you know, depending on where they're coming, which borough, it seems close, but it could be an hour and a half on public transportation. So for like your group and community, I mean, I'm assuming they don't live close. They just travel in, they're willing to come, right?
That's where the hybrid piece came into play. I might do it virtually. So the last one I did, the 9th one, it wasn't on that PowerPoint because I just did it last Wednesday. I did a hybrid. So I had some families on. To be honest, I even have parents that have to work still and ask me, "Can I drop off my teenager?" And I want to participate, but you know, everybody's family life is different. So I will agree to it once they get the information and understand. I had a virtual one. I had a teenager really wanted to be involved. It's a big deal when a teenager wants to be involved. And she signed up virtually and she tried to find an excuse. And I said, "Don't worry about it. It's okay." But they have to turn on their camera so we can see who's there because it's confidential regardless. Okay. And then we take pictures, everyone signs, etc. But I maneuver around the family's needs.
Thank you. Any questions in the chat that we should be going through, or all good? All right. Thank you very much. I have one final question. So once again, looking at this from the adult endocrinologist perspective, these are amazing programs. We could translate every single one of these into the adults. We do some of this as the best we can, you know, on the adult side. What about institutions or locations that don't have philanthropy support or additional support? What other types of options are people leveraging? I always think about length of stay for readmissions and other pieces of that to try and get the administration to buy in, but anything else that people have suggested, tried, had success with? Oh, that's a little scary. Okay. Oh, great. That makes me happy.
At my fellowship at trained institution, it was just voluntary. Like we just stayed. We also did the evening. We stayed. We had group sessions, and it was a lot of fellows, and usually, you know, one attending, one social worker, and we had some of those group sessions. But it was our time, and no funding. I think we brought in food, like the docs and the whatever brought in salads and whatever.
We used to do that too.
I think nobody's gonna pay for the extra time. Our staff who's hourly come in late or compensate next day, so that's covered. Nobody gets overpaid for that. The staff who's not hourly, it's your own time, so you can flex that. And the pizza we buy from the division, so that's something we do.
Thank you.
I was just going to add, we've done this entirely virtually, so there's no cost for food and things like that. And then the staff that stays, they just make up for the time difference on another day.
And that's a great idea. We flex that too sometimes, which helps.
We've done all of the above, but also have leveraged our vendors. And especially if you're going to do advocacy around pumps and technology, get them to pay for dinner and get them to donate the stuff. They're happy to do it.
Yeah. It also, sometimes you can get it as an educational support grant or something like that. Right. It depends on the location of the institution. All right. I think any other questions or comments? We're like right on top. Okay. Thank you, everyone. Really great session. Appreciate everyone's insights.